Good day. I am Dr. Santhosh George Thomas, one of the neurosurgeons at Macquarie Neurosurgery. I have a special interest in neuro-oncology and skull-base surgery with a focus on brain tumors. I'd like to talk to you about an illustrative case with a deep-seated skull-base tumor called a Petroclival Meningioma. Petroclival Meningioma is a benign, slow-growing tumor situated deep within the central skull base. It's an area that is challenging to access surgically. Patients with this condition may suffer from headaches, double vision, hearing loss, dizziness, facial pain or numbness, facial weakness, and impaired coordination. Treatment approaches can vary and may involve serial monitoring in incidental cases, in some cases surgery, some of them direct radiation, or maybe a combination of these methods. At Macquarie, we believe in a team-based approach where we strive to get the best outcome for our patients. Due to the particular tumor location near vital structures, surgical removal is very challenging. Nevertheless, improvements in microsurgical techniques and radiation therapies have significantly enhanced patient survival and outcomes. This is a preoperative scan of the patient. The patient had a large left-sided petroclival meningioma located in the posterior compartment of the brain. Now, being a very slow-growing tumor, it became symptomatic after it reached a considerable size. And by then, it was compressing the cranial nerves and the brain stem, leading to imbalance while walking. This could grow further and block the cerebrospinal fluid circulation of the brain, which is a potentially dangerous condition called hydrocephalus. We decided to surgically remove the tumor. We used intraoperative neuronavigation and electrophysiological neuromonitoring for surgery. Navigation helps us navigate inside the brain. It's like a GPS that allows you to go along a safe trajectory and helps us remove tumor. Because of the complex nature of this tumor and its relation to all the cranial nerves, we have an electrophysiology team that places electrodes on appropriate muscles that can be stimulated using small bursts of current during surgery. Now, this ensures structural and functional integrity of the nerves and helps us slowly dissect away the tumor away from critical nerve structures. And we are able to preserve the cranial nerves both anatomically and physiologically. It gives us an idea of the integrity of motor tracts that travel from the brain through to the spinal cord and innervate the different muscles of the limbs. We also monitor brainstem auditory responses that allows us to monitor the auditory pathway. The facial nerve, the nerves that help with swallowing are also monitored because they are likely to be encased by the tumor. During this long operation, we slowly peel the tumor away from the brainstem and the cranial nerves while preserving them. A small portion of the tumor had to be left behind because removing that bit of the tumor would have been unsafe. This is planned for an adjuvant treatment in the form of gamma knife radiation, which is also available here at Macquarie. This patient made an excellent recovery and is back home now independent. These are the post-operative scans that show a small tumor remnant left behind, which, as I mentioned, we are planning to treat with gamma knife radiosurgery. This is an illustrative case, and the results cannot be translated to all patients. The treatment strategy varies according to the patient and their specific condition. Please talk to your medical practitioner for further advice.